So welcome everyone to my workshop and lecture on Therapy That Works, a unifying framework for psychotherapy. I am so excited to share this with you today. It really is my life's work, and I really hope it is going to help you do this work so much more easily. And at this point, I have now trained hundreds of people in this approach, and everyone's kind of reaction is like, OMG, where has this been all of my career? And so no matter where you are, I've worked with folks who are just entering, folks who've been in this field for 20 plus years. I think we're so long overdue for a unifying framework. I think relief is often one of the emotions, the most frequently experienced emotions as we go through this lecture, because I really sincerely believe I've been doing this work for 30 years. I have been a full-time professor, researcher in the field for 27 years. And all I can say is that after doing a big part of creating this field, I really think we have made it so unnecessarily complex and so hard to do. It is totally burning us all out. It's a high burnout profession, and no wonder the way we approach it. And I also think it affects our clients, because if we keep going down the path we're going with 500 different theories and inaccessible research for the average clinician, our clients are really going to suffer. We are in the midst of a global mental health crisis. It's only getting worse, despite our 500 theories and hundreds of thousands of research studies. We're not doing something right. And I really think, like many other fields, mental health is ready for a unifying framework. So let's talk about it, because I'm hoping this is going to be one of the most stress-reducing lectures you've ever heard in the whole field. So let's get started. So today I'm going to start by just even defining what a unifying framework is and why we should bother with it. And then specifically talk about the evolution of the unifying framework that I will be talking about today. And then I will go into the 6 main components: self, the clinician, collaborative connection. There's a 4-level conceptualization. You can call it analysis. You can call it an assessment. I actually don't care what you call it, but it does have 4 levels. And then we'll look at evidence-informed treatment planning, as well as evidence-informed interventions. And then a 4-level conceptualization of solution and wellness are the main components. So I'll be kind of walking you through all of these components of the unifying framework. So let's jump in. So what is a unifying framework? So a unifying framework is a single way of organizing a whole bunch of diverse perspectives into a very systemized, streamlined system. And the way unifying frameworks typically do this is they look at where all the different concepts and vocabulary overlaps, and they streamline a lot of the concepts and the labels that we have, and so that you can fit these different things that seem so diverse and different, right? Into a single coherent framework by just focusing at the conceptual overlapping. And as you look across all disciplines, and we are seeing a whole bunch of unifying frameworks because we have this knowledge expansion that has happened in the 21st century. Honest to God, when I got into the field, it was probably 1995. I did my first, literature review on mindfulness and Buddhist psychology and mental health. Okay, I'm telling you, 7 studies came up, 7 studies. Today, if you did that search, you would have hundreds of thousands, there could possibly a million. I don't know how much is out there. And so, it was really easy. When I did my dissertation, I did exhaustive reviews of everything written on narrative, collaboratives, focus, qualitative research. I mean, I could do an exhaustive review in the 1990s. You cannot do that anymore in almost any area. I get so excited when I actually stumble upon an area so new that I went, oh my God, I did an exhaustive review. There are only 25 things written on this topic. But most everything else in this field, you try to write about it. There's just more knowledge than a human can actually synthesize and use. And so all of the disciplines are going to these unifying frameworks. So if you look in psychology, we do have some, but not in psychotherapy, but we have a unifying framework for well-being constructs in the area of like positive psychology. Factors for visual attentional processing, bunch of researchers there. Unifying framework for individual differences and mental representation of emotional processing. Again, very focused research area, still needs a unifying framework, which is really stunning because these are pretty tiny little areas, right, of research psychology. A unifying framework for trauma memory process and PTSD. Again, seems like a really small area, but they still need a unifying framework. I'm telling you, psychotherapy is so overdue for a unifying framework. You will see it in their educational unifying frameworks. There's one for early childhood education because it's so different, right? Another one for structured analysis and design models in the area of computer science. There's tons in computer science. A unifying framework for software engineering. And then, of course, the unified field theory in physics is probably the most famous of all of these types of unifying frameworks. So all different disciplines are moving towards this because we just have too much knowledge for the average human to actually skillfully use in their work. So let's ask about, does psychotherapy need a unifying framework? Well, let's think about this. The average licensing exam is going to have 16 to 20 theories on it, but the average clinician can probably actually skillfully use and is actually trained to use maybe 2, maybe 3 of those. We have over 500 different psychotherapy theories in the field. So I don't even know them all. No one knows them all. It's impossible to know them all. And so we talk about imposter syndrome spiraling out of control. Yeah, because no one's going to know the 500 theories, even professors for 30 years who are theoreticians, right? There's no way. It's impossible to actually have in-depth knowledge of 500 theories. So we have very high levels of burnout. And there is research that actually shows our evidence-based treatments, which have really exploded some of the number of these 500 theories, are contributing to our level of burnout because we're just overwhelmed. There's just too much out there. Always feels like there's something you don't know. And if you look at our training, it has become so fragmented, right? You have the university knowledge. I cram 20 to 25 theories into my graduate students' heads. Forgive me, but that's, what the licensing board wants, the national accrediting body wants, and what the state, and what the employers want. So it's insane. There are actually over 295 separate diagnoses in the DSM-5-TR. There are hundreds of thousands, if not millions, of research studies. We have hundreds of laws. It's a lot that we're cramming into your head in grad school. Then you go to your field site where usually they're having you use totally different theories and a whole different way of using this information. And then we have this area of the self-care and self of the therapist. And how do you do this work as a human being and live your life? And what does that look like? That's divorced from both of these other places. And so, we ship you off to personal psychotherapy, but we don't have a mechanism even to integrate that into how you do your work. It is a fragmented field on almost every level. So I'm going to talk about how the framework we'll be going over today evolved. So it really evolved from my work of being a textbook author. And the history there is when I was a new professor, I started working in California where they had an oral exam and you had to do a theory-based treatment plan, right, for your theory of choice, but nothing was published in the literature at all. And so my books actually started to because the only thing you could do is go pay for a $3,000 license exam prep course to learn these theory-based treatment plans. And I couldn't ask my grad students to do that. So I started writing them and then I turned them into textbooks is what I did. And I ended up doing both traditional psychotherapy theories as well as MFT theories. And to my knowledge, I'm still the only person with textbooks in both areas. So I ended up writing about over 50 theories, right, over the years. And this has been going on for 3 decades. And what I did with my textbooks is I really wanted them to be practical as I focused on what the therapist was doing in the room rather than just the theory. So if you've seen any of my textbooks like Theory and Treatment Planning and Counseling and Psychotherapy or Mastering Competencies in Family Therapy, you'll see I have clinical forms in there. I have lots of step-by-step instructions of what to do in the room because that's really what my students wanted. So I started doing this. And so over the years, I'm writing these books. I mean, thousands of hours. It took 4 years to write first draft of each of those books. And so, but as I'm putting it all, it's all going into one brain. And I have to keep filtering and understanding so I can describe it in practical terms. And when what I promised myself when I started writing these books was that even though I have my favorite theories that I had trained with many of the founders in the field, and I do have my favorites, right? Especially at the beginning, I had my favorites, I'll be honest. I promised myself that I was going to practice what's called appreciative inquiry, which is actually related to my collaborative therapy approach, which is with each theory I encountered, I am going to look for the wisdom and the good to understand how does this help humanity deal with human suffering. And I really focused on, finding the beauty, the wisdom, and the magic in each approach. And it's really been 30-year magical journey learning about all of these approaches, because I truly do believe each theory has something so beautiful and solves, human suffering and addresses it from a different angle. And depending on the client, the human who's sitting in front of you that you're trying to help, each one could be useful. And I would be lying if I said that there were theories I didn't use. It's not true. I've never found one that was useless. Problem is you can't use 500 at once. But it's really what I focused on, is finding the gems in each one. And that's why if you're familiar with my books, you'll see that there's the juice. That's what that is. I'm like, wow, this piece is so powerful, right? There's one thing you remember from this chapter, it's the juice. And that's the gem that I'm like, wow, no matter what approach you're using, this is the wisdom. And then the other thing I try to do with these books is really make them relevant into contemporary practice, not what was happening in the 1960s. And so, bringing in all of the research and evidence base, really looking at diagnosis and clinical assessment, integrating that, even though there's some theories, and I note it in the chapters, there's some theories are like diagnosis and clinical assessment, but for the reality is for most of us, we need that to get reimbursed and to get paid. And so around the globe, most payment for mental health services has to integrate diagnosis. So I tried to do that. I also added all the documentation. It started with those theory-based treatment plans to pass licensing exams, but it evolved to progress notes and case conceptualizations and clinical assessments, so that you have all the tools you need and you're not like in total shock when you arrive at your first field site. And then, of course, integrating social justice and working effectively and respectively with a diverse range of clients. There are a handful of theories, we'll talk about those, that have this integrated, but for most other theories, this has to be consciously kind of integrated back into the approach. And so this is kind of where this unifying framework came from. What really happened was that patterns emerge when you focus on what the clinicians are doing in the room versus what they call it. And so there's obviously a body of research around what's called the common factors that addresses, 3 to 4 common factors. But common factors is still yet to become super practical for when you're sitting in the room. But I think many of us resonate with that common factors. Yeah, there's a lot here that's similar that we're calling really different. And one of the first times this really hit me is when I think it was on the second edition of my counseling psychotherapy text. I remember I think I was going through and just, final edits. And I sat back one day, I'm like, whoa, every single chapter here has evolved into some form of postmodern iteration of the approach. So, that's one pattern I saw emerging. Another one is, and someday I'm going to write a whole book on this, I promise you. I just have such a long to-do list, but I'm excited about this one. Another thing that really emerged is that if complementary, so the complementary is kind of looking at opposites, right? Most every theory, CBT is one of the major exceptions, looks at complementary patterns. So you look at psychodynamic, obviously Jung and Carl Whitaker and Fritz Perls and systems and structural and emotionally focused couples therapy and functional family therapy and Bowen therapy, looking at all of these complementary patterns. It's a pervasive theme, and this is probably where we have the most vocabulary difference. But this is how all of these theories are conceptualizing, looking at polarities, look at complementary patterns. And when those become rigid and extreme and highly polarized, you tend to have psychopathology, right? So fascinating, these patterns. I'm like, whoa, so that's how you do complementarity. That's how you do it. That's how you do it. Oh, interesting. And we see it both in the, when analyzing the internal psyche as well as interpersonal relationships. Like I said, the common factors is, still in the works also of trying to find real applied uses of this very clear pattern we're seeing, again, of there more similarities than differences across approaches. And so what emerged from this is not what I would consider integration, because integration, emotionally focused couples therapy is a great example, right? You take attachment theory, you take classic systems, you take some enactment from Minuchin's structural family therapy, and you take the humanistic focus on, emotions and emotional processing, and you put those pieces together and you get this beautiful evidence-based treatment for couples, So that's integration, right? You clearly got different parts from different places. You put them together, and you end up with this new combination of recognizable parts. Where synthesis is something different. Synthesis is like boiling down, kind of taking out the essence of what's going on. So it's really simplifying the language, streamlining, and creating a framework. It's a framework for doing. And so a good example of where synthesis comes about is when you're looking at the difference between narrative unique outcomes and solution-focused exceptions. There's a published book chapter that was actually based on a live conference proceedings in which, you have, Michael White and Steve DeShazer describing how these two concepts are totally different, and they are theoretically, conceptually different concepts. A unique outcome fits in narrative theory and has a meaning there. Exceptions fit within the solution-focused frame, have a different meaning there. I'm a theoretician. I can tell you, yes, they are theoretically different concepts. But for the clinician in the room, they make hardly any difference because you're looking for a time when the problem could have happened, but it didn't. So when you're sitting in the room, that theoretical distinction is just clutter. It is noise. It keeps you from being emotionally attuned to your client when you need to be. So, I'm a theoretician. I like all of this stuff. It's like a little theoretical playground for an academic, but it is wrong of us to be imposing that on the person who's sitting in the room working with the client. That is meaningless noise that is going to keep you from being more effective with your clients. So what specifically is being synthesized in the Therapy That Works framework? First, there are 50 traditional theories, traditional counseling, MFT, and evidence-based treatments. We're looking at the research foundations, looking at both what the outcomes we have in psychotherapy and family therapy. And I would add to that motivational and actually positive psychology as well, in terms of knowing how to help our clients take real world action in a consistent way. And I don't know why we have these really big theories about why people have their problems in our field of psychotherapy. We don't talk enough about how to actually make change happen, how to motivate people to make a difference. And I think this is a whole that I have found, at least in my clinical work, that has really made a difference, is understanding how to motivate people. And we'll also talk about positive psychology and wellness psychology. And then finally, looking at the broader evidence base, and not just evidence-based treatments for specific populations and issues, because there are certain issues that we know only certain approaches work. And then looking at ruling out all the medical issues affecting mental and relational health. And so it is We don't have a profession for this yet, but I can tell you that any of your clients who are not progressing, and even though you're using the evidence-based treatment, the estimate is 25% of the clients we see, that's a huge chunk, and that's at minimum, have a physical health issue that is keeping them from making progress on their mental health issue. And sometimes the physical issue is the primary cause. Sometimes it's secondary, but they can create a very negative reinforcement loop where the physical and the mental health, they just create this negative downward spiral that's really hard to get out of with talk therapy. And understanding that, and unfortunately, there are not a lot of practitioners to refer to for that, but there's a real important thing to know how to, as a clinician, figuring out, who in your area knows how to do this and assess for this, to help your clients, especially those who don't seem to be getting better. And then there are brain-based interventions that some of us, we can use. They're usually highly specialized things like neurofeedback or EMDR, but knowing when, where, and how to connect our clients with the right brain-based intervention for their particular situation, because there are certain clients, again, where these brain-based interventions seem to be what works. And so in terms of this unifying framework, there are 6 main components. The first is the self of the clinician. The second is building a relationship, collaborative connecting is what I call it. And then the next is a form of case conceptualization that also doubles as an intervention. Thank goodness, this is why it's unified. But looking at the 4 different levels, and this is really where the synthesis of case conceptualization from all the different theories come together. And there's evidence-informed treatment planning. So once you kind of conceptualize and really understand what's going on at a very nitty-gritty level, you need to run that through the evidence base to know what works for that sort of issue. Then looking at evidence-informed intervention, there are certainly some problems where only specific interventions work for most people. And there are others where you pretty much have a broad playing field to work with. And then finally, and I'll talk a lot about this because I'm very passionate about it, conceptualizing wellness so that it's easy for our clients to maintain the gains they make in therapy. And I think this is a totally underdeveloped skill set in our field. And we have very high relapse rates in terms of, 50% of the folks who get diagnosed with major depressive disorder who are successfully treated with medication and or psychotherapy end up depressed within a year again, clinically depressed. It's horrible. We need to do a much better job on helping clients maintain, and there are very few approaches that address this in any depth whatsoever. So I want to start by just pointing out the key to this framework. And what we're doing is we're taking knowledge and we're turning it inside out. And so we are taking the entirety of mental health, the theoretical, the research, and the evidence base, and we're turning it inside out. Because what we're going to do is we're going to work within the client's framework. We step into their meaning-making system, understanding how they see the world, and we bring all of our knowledge here, and then we look at what fits for how they're making sense of their life and their problems. And when you do that, it's seamless, okay? And of course, this is the only way. I mean, all of our work, we're always working cross-cultural, across all of the diversity variables of being human. Race, age, gender, sexual orientation, social class, education level. We are always working cross-culturally with all of our clients. And so to respectfully enter their worldview, to understand it from within their frame of reference, if you can bring our knowledge in to fit into their world, you're going to make progress so much quicker because it makes sense to them. It fits for them. It's logical. It's natural for them to make the change. And that is why this framework works so well. We're not just using all of the different theories and then synthesizing it. The true key is that we step into their world and see where all of this knowledge fits from how they're seeing their situation. And the guiding principle of this approach is do what works. So I call it therapy that works. I couldn't come up with a better name. Some people have told me I probably should have, but because any other name you pick, you kind of align with a certain camp, and I don't want to align with the camp because you just do what works. And you have to do what works for the client who is sitting in front of you in each and every moment. And that is really the total litmus test as to what you need to be doing. And you really want to be careful of not robotically using what worked for you, what the research says should work, which by definition means it doesn't work for everybody. There's only one or two diagnoses where we can actually say that. What your theory says should work. So many of us are like, this is what the theory says, this must be going on. And we just keep trying to get the square peg, round hole. It's just a mess, right? You can have your favorite theory and approach that you want to use, right? And that's what you're trained in, that's what you're good at. So that's what you're going to use. And the key is, if whatever you're doing isn't working, you have to be willing and humble enough to drop everything that you think should be working and really look at what is working for this person who is in front of me, and to figure it out no matter what. So you just do what works, whatever that is. And that's truly the guiding principle of this work. So let's look at the self of the clinician. So, I have been full-time supervisor, trainer of psychotherapists for nearly 30 years now. And I think one of the most difficult pieces, and there are reasons for this, our ethics codes have all these things around boundaries, but I don't think we talk enough about the human side of doing this work, who you are as a human, what your life needs to look like as a human to support you in doing this work in a way that doesn't burn you out, drain you, but to say doing this work doesn't affect you as a person, and it's like a job you go to and then you just kind of leave and it doesn't matter who you are, is totally naive. And I do think there is a personal development journey that is lifelong for all of us to be able to do this work joyfully, to get really good at it, and to really be able to help our clients. And I think our personal journeys, what we learn from them, how we in our own lives engage our own problems and struggles, is totally going to determine how helpful we can be to our clients. There's research to support this. So, when I'm teaching folks how to go, when I start teaching people how to use this unifying framework, the first place I start is with you. Who are you? Where are you on your journey? And to really develop a lifelong process of developing wellness in all of these areas. We focus a lot on that, emotional wellness, which for many people connects to spiritual wellness. And that's what we talk most about, if we talk about it at all, right? But physical well-being is so important, I think, to be able to do this work well. Our relationships also, how are we doing our relationships? Are they working? Are they not working? And understanding relationships and engaging them in compassionate, wise, open-eyed and open-hearted ways. But how you live your relational life is also key. Personal effectiveness. So learning how to manage time, money, and all forms of finite resources. We become experts really in kind of infinite resource world of emotions, right? Emotions, relationships, there's sometimes my kids are like, which kid do you love the most? And I'm like, impossible. Mothers have this infinite love, right? There's not like this finite amount of love from my kids. It's infinite. But time and money, and there are lots of other finite resources in our lives, it's a whole different skill set to manage those. And after training folks, doing live supervision, watching what some folks say, if you don't understand how to navigate finite resources in your life, you can do a lot of harm, actually. I've seen harm done by, clinicians with really good intentions, encouraging their clients to do a lot of harm because they don't understand how to manage time and money well. So I think this is actually a very critical life skill. And just for our own mental health and well-being, we have to get good at this, especially because we live in this realm of infiniteness in terms of dealing with emotions. Then there is career development, having a career plan that really supports you, that is joyful, that is doable, that's not burning you out. It allows you to maintain wellness in all other areas and support yourself. And then finally, fun and adventure. Some of us need to make sure we add that to our recipe for wellness, but it is real important, and it is very key to not burning out in our work. It is key to maintaining a sense of our own just emotional, mental wellness. And so having a plan is real important for how you develop in all of these areas. And the other piece of the self of the clinician I have come over the years to really think is critical. And this developed through a lot of my work with mindfulness, another area that I'm very passionate about. But this ability to step out of our own stream of thoughts, feelings, and biases. And in mindfulness, as you probably know, you try to quiet the inner chatter and just focus on the breath. And in that, right, your thoughts will keep bubbling up, but it allows you to step back. And even if it's just a few seconds, you see your thoughts and your mind in action. And you step out of the stream of that inner narrator who does not stop talking, I'm telling you, right? You step out of that stream, and it gives you this ability. They call it the observer. Throughout, philosophers from around the globe have always wondered, who is that part of us that is observing the mind in action, right? That inner observer. But cultivating that ability is essential for forming a highly effective therapeutic relationship, because you need to be able to easily and readily step out of your stream of thoughts, even if it's just for seconds, to step into someone else's worldview and understand how they make meaning from within their perspective. Because if you haven't learned how to separate yourself from that constant inner chatter in your mind, you are going to be far less effective in terms of understanding what your client is actually thinking and experiencing, because your biases, your assumptions are always there. And the truth is, we never get out of our biases and assumptions. Every word we have is at philosophical level, we're never out of our framework. But you want to be able to at least loosen your grip enough so that you can step more fully into someone else's set of assumptions, biases, to see things in ways that you just never thought possible. And if you don't frequently have that experience, like, whoa, I never saw that could be connected there. If that's not happening to you in a regular basis, you need to do more of this, because you should be routinely blown away that this type of situation could be seen this way, interpreted this way, because that is the sign that you're able to step out of your stream of assumptions and biases and step into, quite frankly, someone else's way of making sense of their life. And if you're trying to help someone else from within your framework, you're going to just miss the boat a lot. I don't know how else to say that. So that gets us to collaborative connecting, being able to step out of your own stream of thoughts. Truly, it's just for seconds, but you weaken the bond there. And that is why I think the practice of mindfulness is so helpful to clinicians, is that on a daily basis, you spend 2 to 5 minutes with probably a total of 30 seconds out of your own stream of thought. But if you do that regularly, it becomes much, much easier to do that. So in the metaphor I use, so we think of therapeutic relationship, right? Most of us have all learned the core conditions, at least 3 of them, based on the work of Carl Rogers and humanistic approach, where you focus on empathy for the client. And I start all my students there. This is where we start, totally good with, this is where we start training people to build a relationship. But if that's all you ever do, even, that's like first semester to me. Okay. Carl Rogers core conditions, first half of first semester is where we practice with those. But it is not enough to have a transformative relationship. And I think as we look at the evolution of the thoughts in the field about how to form a relationship, especially when we start looking at social justice and diversity issues, empathy is so not enough to have you use that relationship to truly create transformation for your clients. It is just the first step of many, many steps to getting where you want to go. And then over the years, I've been trying to explain this, and the metaphor I have landed on is the holodeck. And I know it's old school. It's like probably, 30 years. I did watch Star Trek when I was in grad school, so that tells you something. But the holodeck, for those of you who are unaware, is a room that was on the Starship Enterprise several generations back in the Star Trek worlds, where it's this room on the spaceship. You can kind of see the little grid there, and you can see the little panels where you would the user comes in and actually programs the world. This is why virtual reality metaphor does not work. So the user comes in and they program this world, and it is their logic. And in the movie, they could create a childhood scene, a trial, a paradise, a scene from a book. They could, and all the characters and everything, appear. And so the metaphor, so this holodeck, though, is programmed by the user. Virtual reality, you're using software, someone else has programmed it. This room is programmed by the user. And you want to think that your client has their own little reality bubble that they have programmed with their meaning-making system. And our meaning-making system is informed first by our family of origin, by our society, by dominant discourses, by the books we read, the movies we watch, the friends we hang out with, what our school teachers taught us. Infinite variables go into creating this meaning-making system. Half of it we aren't even consciously aware of. And so we all have these little holodecks that we're in. And what I propose is, when you're working with the client, what you're doing is you blindfold yourself. You're blindfolded because you can't enter into their holodeck any other way. They are going to take you on a tour of their holodeck, and you're blindfolded. And the only tool you have are your questions. Oh, what is this? What's that right there? And oh, what's this over here? Do these two things normally happen together? Is this normally how it's like? Oh, wow. What's that water just splashed me in the face? Oh, rivers run through the air here. How interesting. Never thought of that, right? Oh my God, there's a lion. Should I be afraid? They're like, no, they're just grazers. Lions graze here. They're vegetarians, right? It's the gazelles you've got to be worried about. So, and so when I sit with my clients and they're putting together their pieces, right, of how they live their life and why they do things, I can make no assumptions, because truly their world, their holodeck, their meaning-making system, their approach for interpreting the world is totally individual, idiosyncratic. I can assume nothing. And so they have to take me on this tour, and I have to try to make sense of it and put all the pieces together from how they're describing it to me. I often feel like an archaeologist in session. It's like, I see, that means this, and we're like decoding and putting it all together. And so, I was working with one of my clients who's LGBTQ and doesn't actually fit into a single one of those letters, although at some point in the many years I've worked with this person, that we've had identities related to all of the letters, and even yesterday, on and off, I've worked with this person for many, many years, 15 years. It was like, okay, so when you started, binding, there was a conscious effort to, if I look different, then I know why people are treating me different, right? And so there was actually, when they did that, it reduced their overall stress level. I'm like, okay, that makes sense. I get it. And so I stay with clients till it makes sense. Another client I was working with for many, many years, gotten to know the holodeck pretty well, right? And then there was this one situation where their child was launching to college. And it literally took me 3 sessions to ask enough of the right questions to get, because I didn't get the emotional reaction that was happening to the launching, because it didn't fit with all the other parts of the holodeck. And so I had to keep coming back. Sometimes it takes a couple sessions to understand, and finally we were able to identify in words the interpretation of what this kid going off to college, and how that related, obvious, no surprise, to some really old childhood stuff and the relationship with their own parents, and how they were losing this beautiful thing they created with this child. And that, of course, it identified an area for us to work on, how to find your own joy, not just living through children. So but you stay in these holodecks and you're never done learning. You can work, like I said, 15 years, one client, something new every session. And you should be continually surprised by the logic of each client's meaning-making system. Now, you do get better. The good news is you get better and better. Like, so, you know, some of the stuff I'm like, okay, I'm real fast, right? But there are always going to be new corners of the holodeck where you have to pause and listen, and you're never on autopilot. And so what happens is, though, and this is where we pull in a little bit of the neurobiology here, and Dan Siegel talks about how to get into neural resonance with your clients. And when you take a humble, not knowing stance, totally open to learning, assuming you know nothing, you're blindfolded, and you totally try to attune to their world, that is measurable. And that there is this neural resonance, right? Even our brain waves, we feel in sync. There is neurobiology between feeling in sync, but you get in sync with them and they can feel it. They feel felt. They feel like you get them, right? Even like when it took 3 sessions for me to figure it out. They feel felt because they know that you're trying to understand their holodeck. And it is an incredibly intimate thing to have someone else in your holodeck, I'm telling you. And they feel felt, they feel understood. There is a profound level of trust. And so, but there is this neural attunement. And what happens with this neural attunement, it takes, so when I'm in session, my mind never wanders after 30 years of doing this work. I hang on every word, every nonverbal. And I teach it when I get into my, Therapy That Works masterclass. I teach it as following a breadcrumb trail. Like there is this like breadcrumb trail of meaning that I'm following. And it takes 100% of my mental bandwidth to track the meaning. I am totally in their holodeck. There are very few moments. I do sometimes step out into my own little holodeck, right? Run and grab some theoretical books, DSM, do assessment. But most of the time, I am just right there with them, 100% in the moment. My mind never wanders. And that's where there's a neurological attunement that happens there. And so to be that attuned to somebody, okay, so we're way beyond empathy. Empathy you can do very cognitively. This is like a mentally, emotionally, all of your focus is on the meaning that is unfolding in the conversation between the two of you, you trying to understand this, quite frankly, foreign holodeck. And so you can't have a lot of theoretical clutter in your mind, which is why you'll see when we get to case conceptualization, and it is so simple. It is so basic. Because if you have a lot of theoretical clutter in your mind, you are not going to be able to keep that attunement. You're going to lose the thread of meaning. And so this is the key. This is what you can never let go of, is this attunement that you're in their holodeck, following the meaning as it unfolds. And it's like this little thread you're not going to let go of. And yeah, you're going to quickly reach over to a couple little things here. What's the behavioral part, emotional part, cognitive part? But you stay focused there. And that is why the conceptualization is going to be so simple. So let's talk about that. So we have case conceptualization. So in this approach, we're going to use a 4-level assessment. And the thing I want you to really think about here, because this is where the synthesis happens, and we have a little bit in the case conceptualization. We got Rogers, we got postmodern, we got the neurobiology, right? But here, when we get to the case conceptualization, this is where we have maximum synthesis. We're synthesizing the 500 different theories into a very simple, streamlined approach. And if you think about it, all theories that we have, all 500 of them, are addressing the exact same client and their exact same reality, the exact same holodeck, okay? All theories are addressing the exact same thing, but each is focusing on a very small portion of it. So none of them are wrong per se, but they each have a very different piece of the pie. As if you're familiar with this traditional Indian kind of metaphor of, 5 blindfolded men who've never experienced an elephant before, meet an elephant and one's touching the tail, right? And they're like, yeah, this is like a rope, another one's touching, you're like, what are you talking about? This thing's a wall, right? This thing ain't touching the side of the elephant. This thing's like a wall. This is incredible. There's another one who's like touching the ear. What? This is a little fan that blows, right? Another one's touching the leg. It's like, you're crazy. it's like a tree trunk. Can't you feel this? Right. And the other one who's got the trunk is like going, this is a snake. You all are just, what are you guys thinking? This is just like a snake, right? None of them are wrong, right? They all have a piece of the pie. And they all have a piece of the truth. They all have a corner of the holodeck mapped out. Totally. No one's wrong. No one is wrong. And so that is how I can both love every theory I've ever studied and also say, wow, y'all just got a small piece of the pie. You're doing beautiful work with each piece. But there's this huge, big reality of how those pieces fit together because it's all one client, right? You have, if you've ever seen the old Gloria tapes, right? You have all these 3 different clinicians working with her from totally different angles. Same human problem. Totally different realities, perspectives, analysis of the client. And so this is what I think we really need to stop doing in our field. So this is where synthesis really comes together when you're pulling all these different theories together, using as neutral as humanly possible, minimal theoretical language. Intentionally, I try to take as much theoretical language out as humanly possible, and to just make it super easy. Because like I said, if you're going to be attuned, you can't have a complex set of theories you're going to draw from when you're sitting in that room with the client. And so I call it a 4-level case conceptualization. It's also, some folks like to call it the 4-level assessment. You can call it a 4-level filter if you're postmodern. And when you start using, because this whole assessment can be repeated every session as an intervention, then I think it makes more sense to call it a 4-level analysis. But it's like 4-level conceptualization, analysis, filter. I don't really care what you call it. And so what it is a little complex, even though we keep things at 4. This is probably when I teach people in the master classes, what takes the longest to learn, because you are synthesizing a whole lot. We are going to deal with the whole elephant, not just one little part, like most theories just handle a little part of the elephant. Doing the whole elephant. So there are a few parts, but the beautiful thing is once you get used to juggling these 4 levels and the 4-part cycle, you just repeat it with every client, whether it's intrapsychic or interpersonal. You can use it as your default intervention across all sessions. It really becomes this incredible utilitarian tool that addresses everything. So let's look at it. So the first piece of this conceptualization is something you would probably recognize. You may have learned this as part of the cycle of violence. In family systems, we see this a lot. And actually, if you do functional assessment in CBT, you'll see elements of all of this. So if you're familiar with dialectic behavior therapy, it uses a functional assessment. But what you're going to assess is when things are normal, which is when there is no problem. So with panic attack, you have moments without panic. With depression, you just have less depression, more depression typically. So it's going to ebb and flow. Sometimes you have no symptom, full symptom. Sometimes you just have less symptom, worse symptom. But you're going to assess, you always start from when things are at their best or most quote unquote normal. This is homeostasis is another word for it. Then you're going to track how tension rises, how the symptom tends to get worse. What are the first signs of trouble, right? And then assessing the problem or symptom at its worst. This is actually what we're doing with diagnosis, is focusing just on that part. And then taking the time, which most people don't, to look at how things get back to normal. What type of things are happening when things get back to normal? So this 4-phase cycle of the symptom, so what's beautiful is you can use this for intrapsychic and for couple, family, relationship problems, whether you're talking to the individual, whether you're talking to the couple, family, and even when you start working with organizational systems. This is the pattern, the symptom pattern. And you, obviously they're more, complex and simple versions of it. But this is whenever you have a symptom, you are tracking this from no symptom, symptom getting worse, symptom at its worst, how things get less severe or how things go back to normal. So this pattern is key to always be assessing. And when you look at this, you'll see that if you look at system and CBT, most of their interventions are focused in that rising part. So that's where their focus is going to be. When you look at diagnosis, it's always measuring the symptom at its worst. And that's why diagnosis is not super helpful. There is some benefit for us in diagnosis for mental health, psychotherapists, counselors. There is some benefit for diagnosis. It gives us this like general direction, make sure we run through the research base. But for intervention, it's not super helpful. I would say psychodynamic and humanistic have the most interventions for symptoms at its worst. And then when you look at solution focus, postmodern narrative, a lot of what they're focusing, any strength-based approach is focusing on the return to normal. So you can see if you're hitting all of this, how you're going to be pulling in wisdom from all the different approaches, because they're just focusing on different aspects. And when you assess in this way, you can lean more systemic CBT if that's what works for your client. You can lean solution focused, postmodern. You can go more, psychodynamic, humanistic, end up with really good psychiatric assessments. I'm telling you, my ability to diagnose is unparalleled when you use this 4-level assessment. It is incredible how well you diagnose. But you can move, different approaches. You can see already here how all of these different theories are just touching different parts of the elephant. They're touching different parts of the cycle. And when you begin to get that, you can move back and forth. This is why therapy that works. You go to whatever side of the cycle works best for your client and their problem. So that's the first level, first thing to get. And then we take this symptom cycle and we're going to like unfold it almost. I think of it like a slinky almost. I just and we've got 4 levels that each have 2 levels because a human brain can track 4 for better than 8. So there are then these 4 levels, okay? And the first level we're going to look at is the behavioral level. So what would a video camera see? The next level is emotional. Next level is cognitive. And the top level is social location, a societal level. And so when you're assessing the quote unquote problem, you're going to look at it at all 4 of these levels. It's like a slinky that opens up. And then each of these levels has 2 different parts to fully capture all the 50 to 500 different theories. And I always start at the bottom with the behavioral level. And in my mind, that's just behavioral is where it all starts. And so you always start by getting a behavioral description of what's going on when things are when the symptoms at its least severe, how things start to get worse, when things are at their worst, and how they come back to normal. And so when I teach my masterclass on the Unifying Framework, my Therapy That Works course, this is actually one of the skills that folks say is the most helpful thing, is that they weren't truly slowing down enough to get the whole behavioral description. And once you have that, it is amazing how many pieces fall into place, how solutions just tumble out of the conversation. So most of us want to race to the emotional or cognitive levels. And I make them stay at the behavioral level, and everyone's like, wow, I just breeze over it because it's kind of boring. I think it's boring to most of us who are interested in this field. And so slowing down to get that really clear behavioral description, really does significantly increase your ability to be helpful to assess, to identify solutions and interventions. It's what most people tell me they were skipping before they took my class. But with this, though, is where the complementary patterns can be, identified. So that's the pursuer and the withdrawer, the overly emotional partner and the underly emotional, or even within ourselves, we can have contexts where we're overly emotional, contexts where we're under emotional, where we overfunction, underfunction, right? So looking at those complementary behaviors that we have, whether it's intrapsychic or whether it is interpersonal, that is usually a very helpful handle that many, like we talked about, many theories use that as their handle. Then the next level, what you're going to do though, is for the next level, you're going to actually walk your client through what were their emotions. So you get this movie of, what happened, whether it was in their mind or whether it was, in real life. But even with depression, anxiety, I try to get a picture of what they were doing, like sitting in their bedroom or what they did. And then we look at the emotions, and we look at both primary attachment emotions as well as secondary, more readily expressed emotions like anger, frustration, sadness. And so, as well as attachment emotions, like emotional safety is normally what you're looking for there, and their sense of emotional safety. And we look at how that ebbed and flowed throughout the cycle. And in most cases, I can tell you their emotional safety was threatened, is what gave the rise in tension for most people. So what was the moment? What made you feel unsafe? That's usually where the symptom cycle takes off. And so you begin to identify, give words, give language, and understand the unique ebb and flow for your client. You know, what made them feel safe again on the other side to return to normal, right? So the primary emotions, you're tracking that. And then you're looking at the cognitive level, where you're looking at, so what thoughts and beliefs and or schemas are actually going through their head or underpinning of their behaviors, and then looking at what type of identity narrative, what are you telling yourself about who you are at each phase of this cycle. When things are normal, how do you see yourself? How do you value yourself? When things start to get worse, you know, versus when things are at their worst. You know, most of us have a whole different identity narrative when things are at our worst than when things are at their best, right? We have a whole different sense of self that shifts. And then often there are all these family or childhood narratives that come playing in, spilling in, you're just a loser, you're stupid, you're whatever, right? So we track all of that along the cycle. And then at the top level, we look at dominant discourses around the problem, about, you know, right? So what does society say about people who have your type of problem, you know, and how that lays out, you know, and then, you know, and then looking at the discourse, the discourses around your social location. So age, gender, you know, education level, race, ethnicity, sexual orientation, gender identity, social class, right? And, you know, I think one of the most fascinating things when you're working with a couple, look at how their gender identity narratives shift from when they're getting along well to when they're not getting along well. Totally different, very eye-opening. So what you do is you work with your clients to work through these 4 levels. And, you know, it can take a couple of sessions sometimes to get through all 4 levels initially. But each time you do it, let's say you're working on someone around anxiety, for example, or depression or panic, you're going to find that, oh, yeah, emotions pretty similar, triggers are similar, you know, cognitions are similar, and the discourses. So you get faster and faster at doing it with each of the different instances. But these are the, you know, when you walk through this a few times with your client around incidents that have actually happened in their life, you get a very intimate mapping of their holodeck, of their inner world. You understand their symptoms. Once had a client who was at the OCD clinic for Los Angeles, right? OCD is what I've got. OCD is what everyone's been, you know, telling me. And it was during the pandemic. And so they stopped going there and came to see me. But I tracked her anxiety. And it turned out, yeah, there was an OCD loop she did. Sometimes if you have multiple symptoms, you can multiple basic loops. It was an OCD loop she did, but that was the least of her anxiety issues. There were 2 other anxiety kind of loops she would do that weren't formally OCD. They're more generalized anxiety and, you know, different ways of doing anxiety, but it wasn't OCD. And so you get incredibly precise, not just DSM diagnoses, which are really broad strokes, not super useful, I think, for those of us who have to do the talk therapy, but so now we were able to identify the 3 different anxiety loops she did within the first couple of sessions, and how each one was different, and how each one needed her to, you know, she had to do something different to manage each one outside a session. So finally, she was able to make progress because everyone had labeled it OCD and didn't notice that there were actually very different ways that her mind moved through different types of triggers. So you become incredibly clear and precise with your diagnoses. You have this intimate insight, and let me tell you, no one's conscious of all of this. We all need someone to help walk us through this. And so clients get to understand what's going on at a much deeper level. So just doing this gives them a lot of insight. And this is where we can go ahead and map out all of the different theoretical approaches. And so you can see, and you probably already guessed, that societal level and those identity levels is really where postmodern and social cultural theories really shine and what they focus on and where they do most of their interventions, right? And then when we start looking at systemic structural CBT, they focus a lot on that cognitive level. And you'll notice down below, they also do a lot of the behavioral pieces, right? So they're focusing on the behaviors, the thoughts you're having about it, and they intervene at that level. Then you have the humanistic approaches that really focus on that emotional level. That's where most of conceptualization and intervention happens for the humanistic approaches. They do some of the complementary patterns, like I said, that is key to a lot of approaches. And the psychodynamic, again, is really, they've got a lot of the focus is on that primary emotion as well as complementary patterns. And if you're turning with internal family systems theory, again, all of those parts are patterns, internal patterns that are complementary. So, and I just like to always point out the CBT is really interesting. They're one of the only approaches that really doesn't do complementary. I guess postmodern social cultural, not as much. There is, you can see some of it there, but it's not as much as other approaches. But DBT is the main exception in CBT world in that it does look at those complementary patterns more than the other approaches. That's what the dialectic is. So if you think of what Linehan did, you're like, she brought the way of looking at complementaries into the CBT world to deal with more complex problems. And in general, the more complex the problem, the more you're going to need that analyzing that complementary level to be able to help them. So you can see now how all these different theories are like layering on top of each other, because it makes sense. We're dealing with the same elephant that's in the middle of the room. And historically, everyone's just had one little piece of it. But when you put it all together, you're going to be so much more efficient as a clinician. So next, I want to talk about evidence-informed treatment planning. And so once you really understand what's going on with your client, like my client who came to me with this big official OCD diagnosis for 5 years, who turns out, that was the least of her 3 anxieties. But you need to filter that all through the evidence base to see what works. And this is another huge gap, I don't know, in our literature. For the average clinician does not have access to this in the way an academic does. And there is, medical doctors have huge databases and lots of established books that make it really simple for them to synthesize the research, know what to do, know what standard practice is. They can just look through it, go into a database. There's always been a book for them, what medication to use and all of that. That's just easy for them to access. We don't have that. And so that certainly is a huge gap in the literature. So looking at what the research says, what works for this problem, for this type of demographic. So we have a sense. Now, do you religiously follow this, blindly follow this? Absolutely not. You have to take that, bring it into the holodeck and say, hey, do you think this will work for you? But it gives you some clues as to where to start, what you might need to be referring out for in terms of, could there be physical health things going on? Could there be brain things we need to be, looking at? So it gives you a really clear map. I'm working on getting that book out. Just give me some time, but it is in my class and I've started there. But it certainly is the next step once you have a really clear assessment. Then there's evidence-informed intervention. So some interventions are better than others for certain problems. I'm going to pick on OCD because it has the most research there, or one of the ones that has the most, I actually left off. I guess oppositional defiant disorder and conduct disorder also. So OCD, right? We know that exposure and response prevention therapy is what works for 95% of the clients. Cognitive interventions, intervening at that cognitive level, typically does not work for OCD. Now, once you get that, you'll see lots of clients where you do the cognitive interventions, they don't work. Then jump down to behavioral or emotional or societal. And that's what's really nice. If the cognitive interventions, which is what most of us default to, the average clinician, we just rush to cognitive. We just love, whether you're postmodern or CBT, doesn't matter. We tend to just run there. So that's not going to work for OCD. It's not going to work for certain clients and certain problems. I've had clients where, research says OCD, the cognitive stuff works very well often for generalized anxiety and depression. It's not working for that client. So I had to find a different level to move to. Conduct disorder, it is a family-based intervention that's clear. It is the best intervention. There are many evidence-informed, evidence-based treatments for conduct. So, they're eating disorders. Yes, again, when it's adolescence, one type of intervention works. For adults, a different type of intervention works. And so you need to know that, and you need to be able to offer that to your clients, discuss it with your clients, see if it's a good fit. Exposure therapy is not fun, man. It is very unpleasant. And so, but it's still something you can offer your client. Do you want to try this? Do we want to start here? this is what the evidence says. And again, there is this collaborative working with your clients side by side in a partnership to see, to identify what to try, how to move forward. But there are many diagnoses where the research is very clear. Certain things are more likely to work better than others. And I think ethically, morally, we owe it to our clients to at least let them know about these possibilities and to offer them that as a place to start. And then finally, making change last. And I think this is certainly an underdeveloped area in our field. So, and I do think solution-focused therapy has done the most work in this area, and I still think there is so much more we can be doing to help our clients maintain the gains they get in therapy. When you look at the global epidemic we have with mental health, a large part of that is that we haven't figured out how to make change last. We can go in and help people, but it only helps them for like 6 months. We need to get so much better at this. And this is especially critical for any of our clients who experience marginalization. And because if you come from a marginalized group in whatever society, community that you're living in at the moment, because that can actually change across your life. But what happens is you don't have a lot of people in your environment who are going to reflect back this new identity and sense of self and these new behaviors and reinforce and validate this new set of behaviors and identities that you have created in therapy. And so it's so much more important with anyone who is marginalized. And I'm talking little m marginalized. You can be marginalized within your family. If your family has you labeled, I don't know, as the dumb one or this one or that one, right? The problem child. Even within your family, you can be marginalized. Solidifying that new identity is so much more important because there are going to be so many external hits coming at you that are going to push you back into your symptom cycle. So getting good at solidifying gains is totally underdeveloped. I think the best template we have is solution focus. And I think, well, you can see there's 8 levels I think it needs to be done on. And this is a huge area of growth for us if we're going to deal with this global mental health crisis that we are experiencing. So there are 3 things I think we need for long-term change. First is redefining our goal as developing equanimity versus happiness. The second is learning how to do that same 4-level assessment of positive outcome. Good news is almost the same thing, just positive outcome. And then to really master and help our clients solidify the 5 pillars of wellness so that once they're done with us, they're able to maintain those gains for years and ideally decades before they need help again. So equanimity. So this comes out of Buddhist psychology, and equanimity is defined in Buddhist psychology as the ability to move gracefully with life's ups and downs. And in the West, we're very obsessed with happiness. We pursue happiness often at all costs, and we talk a lot about happiness. But if that is the goal, it is a theoretical, idealistic construct that is not sustainable as a real life human. And so I think the Buddhist concept of happiness is going to come, it's going to go, but life is going to always ebb and flow. There are going to be challenges, there are going to be problems, from the external world, from within yourself and your own relationships, within your family. You're going to experience loss, you're going to experience health issues. The loved ones are going to experience loss and health issues, right? And if you're just trying to achieve happiness, and the way, at least in the United States, so many of us do this is, I just want to be like on cloud 9 all the time. Life is great. Life is good, right? It's always good, always. And oh my God, it's terrible, awful, horrible, bad, something bad happened to me. I didn't get what I wanted. And so, yeah, you're not going to get what you want a lot in life because we don't control it all. And if you can help your clients learn to move gracefully with those ups and downs, rather than, oh my God, we have eradicated anxiety, we've eradicated depression, we've eradicated your couple of arguments, right? Sometimes I think couples come to me and they're going to be like, we're never going to argue again after couples therapy. I'm like, yeah, you will. You're just going to be better at it and more effective, and hopefully it'll be shorter and you'll be skillful. But you're still going to argue still because you're 2 humans that are different. And folks who have depression, anxiety, you're going to have everything that triggers you then is going to happen again, and more pressure. We got to figure out how you're going to weather that in the future. So, but when your goal becomes equanimity, it does change what you're doing. Because with my clients, I don't just look for the absence of symptoms. That means nothing. You can have someone who's clinically depressed, falls in love, and their symptoms go away, but they have done nothing to change their interaction cycle around stressors, okay? So I'm always watching, how are they shifting their default response, that interaction cycle we talked about, to triggers. That's the that's the prize. Let's keep my eye on, that's the prize, that when a trigger comes, you handle it differently. That's always what I'm looking for. And that comes down to equanimity. Again, we're going to use the 4-level assessment, just like you saw it for the other problems. So it's beautiful. Once you get good at this, it's really simple. And so the exact same way, we get the behavior, the movie of what happened, looking at the complementary patterns, the emotions, the identity, the social dominant discourses. It's so much more fun to do this one, let me tell you. It's just so beautiful. And so looking at, what they did differently, and how they were able to shift it after there was a potential trigger that could have resulted in the problem. In one scenario, you're looking at how the alternate, symptom came to be. And so this can be so empowering. It's so much fun. I love doing these cycles. Just recently I was working with an adolescent who had been in and out of treatment for 7-8 years, inpatient, and all these fancy evidence-based treatment, protocols, and the best of the best, still depressed, and actually, strangely, without the typical trauma you would see with this. And boy, just teaching her how to track the cycle, and oh, look, this time you did this, and look how everything shifted, and your parents were happy with you, you didn't get in any trouble. In this case, your siblings are getting in trouble. And so we track all of that, and it shifts their identity. And how did your parents respond differently to you? How did you feel differently about yourself? What were your emotions like through the whole thing? It was really hard to not make a snarky comment, but when I didn't, they stayed focused on my sister and her bad behavior, not me. And wow, that felt great. So, and I really, especially with this, I had so much fun because we just totally went into all the little details and all the different levels, and just realizing how, if I just do this one thing, the whole cycle shifts. I see myself as a different person. Others see me as a different person. I have a whole different reality, and I have control over that. So this is, I always had the most fun here. Then again, you're going to go through all 8 levels apply, the complementary patterns, right? In this case, this one was flipping it with good kid, bad kid, with her siblings flipped when she just didn't add the snarky comment to the conversation. Who was the problem child? Totally flipped. It was like, oh my God, that's so awesome. And just looking at, her primary emotions, feeling safe, the emotions that she was able to express. And of course, in the rise of tension, it was like, oh, I'm so mad, I'm so this, I'm so that, but I realize if I say something, I end up being the bad kid rather than letting the focus go where it needs to go. So, and just how they see themselves, in terms of their identity, where they fit in their whole family, how the family actually gives them feedback, and then looking at the societal level. And so what so many of my students tell me in my class is that being able to have this 4th level where I can talk about dominant discourses, about, in this case, it was, what type of adolescent are you, right? Are you that, horrible adolescent kid to, this really mature young adult, right? Totally different narrative about how she saw herself and how she identified, how others were identifying her. And so, but having a very comfortable way to talk about this. So how do you feel about yourself, in terms of your various intersecting identities at one, when there's no problem versus when there is a problem, or versus when you handle the situation differently, right? And so, wow, all the society stereotypes, I don't know, about being a Latina female, right? When I in my solution cycle, that I am bucking that narrative, and it feels so good to me. So you can really bring in these social, societal level discourses. And I have so many of my students have said, sometimes I didn't think this client had a lot of dominant discourses to talk about, and I'm always surprised. And it's true. If you open that door, you will be shocked at just I mean, most of us have at least 15 to 30 different dominant discourses, identities, intersecting identities that come together in really surprising ways. And if the therapist opens the door for it, then clients will talk about it and you make those connections. They're super profound and very motivating. What you'll find is when you hit that identity and the societal levels, it really motivates clients to do something different. Because it plugs into these really powerful narratives that sometimes are from family of origin, which are also all interconnected with dominant discourses, and just also at the societal level, extremely motivating. And then finally, you're going to talk about the 5 pillars of wellness. And this is what mountains of research tell us all of us need to maintain mental and physical health. And the fact that we don't, I mean, yes, we can't prescribe healthy sleep patterns, but we can identify them and we can share the basic, information that you need to be getting 7 to 9 hours of high quality sleep. Otherwise, you're likely to have a lot of mental health issues. And so my clients who have chronic sleep issues, that's one of the things we need to address if they're going to maintain long-term mental health. It's one of the cross-cutting symptoms in the DSM-5. Super, super important for us to make sure that is working for our clients before we send them on their way. Developing a healthy eating patterns. We know 80 to 90% of what we eat should be whole food from the ground, right? And that there's increasing shocking evidence of how, things like food sensitivities can really masquerade as anxiety, depression, bipolar, and even psychosis. Okay. And I've had clients do all of these things and we find that it's a gluten insensitivity at the root of it, not something else. And certainly if you have those issues, even if the psychotherapy helps with part of it, they're not going to be able to maintain it unless they have a healthy diet. And then we just know everyone, if you eat too much processed foods, it can definitely contribute to depression and anxiety and mental health symptoms in general. Regular exercise. Research shows it's actually 1.5 times more effective than your average antidepressant for for many clients, kind of frightening. But regular exercise, 150 minutes of moderate intensity aerobic exercise, definitely mountains of research, decades of research supports long-term mental health. Having supportive relationships, a community, having intimate people to talk to, as well as a larger social community that is supportive. It may not be your family of origin, but they need to have them. I never let my clients leave treatment unless we have a couple of strong confidants and a community that are plugged into to support them. Because the research is crystal clear. They're not going to be able to maintain their gains without that. And then having really healthy coping strategies for stress. So this is not a margarita on the beach. This is mindfulness. This is religion. You're going to religious practices. This is reading inspirational literature. You can use going into nature. You can use exercise, relationships, but you need healthy coping strategies. And that needs to be in place so that when you send your clients on their way, they know how to intervene at the first rise of tension to keep their symptoms from coming back. And when my clients master that, that's one of the things I'm looking for before I say we are done here. So putting it all together, this is a lot. Okay, you probably need to come back to it, but I just wanted to put it up once. So putting all those components together, you start with who you are, becoming, working with your biases, being on your own personal journey, and being well-rounded as a human. In module 2 is this where I teach collaborative connecting. And there I teach it very simple. I talk about getting the movie, get the behavior, and get the basic interpretation. Okay. And this is when we're just getting the lay of the land. And in module 3, this 4-level conceptualization of the problem, once you have a good example of the problem, you're like, that happened last week. I'm like, great. We're going to unfold that like that slinky and understand the 4 different levels. And then we're going to actually filter it through the evidence base using evidence-informed treatment planning and intervention. And you can intervene at all 4 different levels. We saw that one chart where different therapies, focus on different levels. And then finally, you solidify change by going through the 4-level conceptualization of a solution. It's a lot to look at once. I understand that, but I think you can see, whoa, wow. It's basically 4 different levels, kind of reorganized in different ways, but it's synthesis. That's why I talk about synthesis, not integration. We have boiled it all down to these key elements. And, this is ultimately not a lot less than most theories to memorize, but it's super streamlined. You can think about these few little components when you're sitting there being emotionally tuned to your client and being able to really pull from that. So that is the, in a nutshell, putting it all together. And so I like to also just kind of point out that for those of us who are doing psychotherapeutic intervention, professional counseling, family therapy, most of our interventions, most of what we need to identify and assess, and most of where we're going to focus on our change is in the rise in tension or the return to normal. And so that is where we focus on, where diagnosis is really focusing on the symptom itself. It's, part of the key to therapy that works is really taking the time to understand this whole symptom cycle and the whole solution cycle, because that is what gives you everything you need to know. I would say 80 to 90% of my sessions, when I track these cycles, I don't have to do intervention, like literally tumbles out of the conversation. The client will say, well, this is what I need to be doing because they saw something different, because you're putting together all these data points that they've never noticed before on their holodeck. And then it's like, well, it's clearly this. And so it becomes so much easier. There are clearly times I need to do, more structured, formal, what we think of as intervention. But most of the time, I just walk into their holodeck, blindfolded, try to understand, track it. And the intervention, the next step, the thing that needs to change just becomes obvious. It just literally tumbles out in front of us like a present. And that is why it's kind of easy to work this way. And so another way to think of this too, what happens is most of the time, when it's a week to week, what am I doing with these people, right? So what you're looking for is shifts typically in the rise of tension or return to normal. Were they able to do anything different when tension started to rise? Were they able to get back to normal more simply? Were there other things that help them get back to normal? And so each week, typically what happens is the symptom cycle, the events of the symptom get smaller and smaller and smaller. And I focus, what did you do different when you got triggered? What did you do? What happened different? Or what did you do different to get things back to normal? And we just make the circles smaller and smaller and smaller. And then what will also happen is we will sometimes jump into the solution circle, right? Oh, so you were able to, not get triggered when you normally would. Let's mine that set of 4 circles, right? This is what was different there. So then we need to do this next week. So basically week to week, I'm looking at exactly how the symptom happened again and what was different, hopefully, ideally, what they did differently to make the cycle move through the symptom cycle so that their symptoms were less severe, or they lasted less long, they were less frequent, and just tracking that. And slowly but surely, those symptom cycles get smaller and smaller and smaller until they go away. And usually at the same time, the solution cycles are getting bigger, bigger, and bigger until that becomes the dominant norm. And so in some ways, it's so easy. But it's not boring, because you're always tracking minute differences, right? And different shifts in meaning. Recently, I was working with a client and we had tracked her basic symptom cycle, okay? And then what we discovered, because there was another event that happened, it was different depending which family members were in the room. It was like really eye-opening, like even as a family therapist, like, whoa, like the other person wasn't speaking, but they were in the room, and that changed the whole symptom cycle. So then we had to map out 3 different cycles depending on who was in the room. And let me tell you, that was eye-opening to the client and really motivated change and made change super easy. So, but you're always kind of tracking these symptom cycles and how they get bigger and smaller, and the solution cycles bigger and smaller. And literally, as you're tracking these, what needs to be done next to change things just tumbles out of the conversation. And typically the reframe is like done for you. So where to go from here? So I really believe the field of psychotherapy, I don't even think it has a choice, but to move towards using unifying frameworks. We have way too much information. We have a totally burned out, overwhelmed, exhausted workforce. We don't have enough practitioners to go around, and to be using these older theories that are just like holding on to one part of the elephant is like, I don't have words for it. And I do have to teach these theories. I teach it in my Laughter Way to Licensure course. I teach it at the university, But when I do, it's like, wow, this is such the slow way to do it. I don't know how else to say it nicely. I don't think our field has a choice. Like all the other fields, we are going to have to move towards unifying frameworks. We have overwhelmed ourselves. And I think we've been more stuck than other fields because our theories become almost like little religions, little cult-like groups. And we get really embedded and we fight with each other. And there's all this infighting. It's like, okay, guys, we're all looking at the same elephant. Let's not fight over this. We all have part of the truth, right? But these unifying frameworks that can help you see the whole elephant, we have to move that way to deal with our global mental health crisis. I am working actually on looking at how we license people, memorizing 20 different theories. I teach it because people need to know it, and I'm really good at teaching it. And I am working, I'm doing a research right now on the MFT exams. And I finally get to write a discussion section where I get to propose, we need to stop doing 20 theories on a licensing exam. This is kind of nuts. But I think licensure also has to go that way. And I think just really in our field, appreciating different theories, appreciating different professions, we need to work together. There's a global mental health crisis. We all have a part of the puzzle, right? A piece of the answer. We're all touching, each different discipline is touching part of that elephant, and to be attacking other people who are just more skilled at, addressing other parts of the elephant is not helping the world solve this global health pandemic. We do have to really appreciate that we all have part of the knowledge. And if you're excited and you want to learn more about this unifying framework, this is something I've been developing for years, kind of silently in my head, and I've started, teaching the last 3-4 years. And you will find in my textbooks right now, at the time of this filming, I have just added the Therapy That Works, a unifying framework, to my Mastering Competencies and Family Therapy textbook. Hopefully in 24, 25, you'll see it coming out in my Counseling Theories textbooks, but you can see it first published there. I do have master classes at therapythatworksinstitute.com, where once or twice a year, I do a 45-hour course, and I just teach you how to do this work. And so we do have a level 1, level 2, and now I'm starting ongoing kind of consultation mastermind groups so that you can really learn to work in this way. I got books and articles in the works. I'll probably post them here with this YouTube once they are published. And you're welcome to stay connected with me. I'm very passionate about this work. If you like this concept of a unifying framework, so I have a mailing list where I give free CEs, I share the updates, and that you can just join that for free on Therapy That Works Institute. You'll also find me on several different social media platforms: YouTube, LinkedIn, Facebook, Instagram. So you're welcome to stay connected with me in this way. Awesome. So right now I'm going to go ahead and take some of the questions that have come in from the live audience. So my first one is, can you give an example of how each model has evolved into a postmodern version? Yeah, so this is coming in from Sophia. So psychodynamic has evolved into a more postmodern approach that actually takes into more cultural variables into consideration. It's got a relational matrix, what they call it. I summarize that in my Counseling Psychotherapy book. Let's see. And then also CBT, Meichenbaum, who is a classic CBT type of folk. Most would call him modernist. He has evolved to have a much more postmodern approach. And even within the humanistic approaches, Gestalt and such, there are folks who started creating some more postmodern versions of that. So there are lots of different therapeutic approaches that evolve, because the postmodern piece is bringing in that societal level, that level number 4. It brings that piece in. And so most approaches, to be relevant in the 21st century, have had to integrate that. So hopefully that makes some sense. Okay, I got another question coming in here. Why are some therapists combining narrative and solution focus, and others say it's impossible to combine those two? Oh my goodness. Well, this is my opinion. I'm just giving it. And yes, apparently, Mark, there'll be people who agree with me. I would say most people practicing today who practice solution focus combine some narrative with it, and vice versa. Those two have a ton of theoretical constructs that look very similar in the room. Yes, they label it very different theoretically. And so writing a graduate level paper or publishable paper, combining those two, it's doable, but it would be very challenging and most people couldn't do it. I would say that. So I would agree with those who say it's impossible. But practically in the room, they are doing a lot of the same things, okay? There's a lot of overlap between those two approaches. So I totally disagree. And in fact, I think you should be able to do it all. So that's my answer to that one. Okay. Yeah, so we're getting a question here from Steve that, yeah, he didn't think he got enough training on specific evidence-informed interventions. Probably didn't. That's probably correct. Any advice for becoming more knowledgeable on what works for specific diagnoses? So that is a huge hole in our literature. And I didn't realize we had it till I was invited by Scientific America to do a encyclopedia entry, which was like a 40-page document for the record, on how to use family therapy as an intervention for psychiatrists, because psychiatrists have this lovely database that has all the different interventions, mostly medications, but they also put family therapy in there that summarized it all for them. We don't have that. I'm going to work on publishing a book that has that in there. I do have it as part of the training in my Therapy That Works course. I think the next closest thing would be Jay LeBeau's book on psychotherapy for the research for the psychotherapist is the only other place, but even that's not as clinician friendly as I would like. What I teach in my Therapy That Works course is I actually pull out the whole DSM and then we march through every diagnosis, every evidence base, what the evidence base says for each one of those. But it does really help, especially with certain types of clients. Okay. So another question is coming in it says, when you're doing the problem-based or solution-based 4 levels, are you guiding the conversation to get that information? Yes, I am. I do. I typically will say something like, I want to slow down here for a moment and really get a good understanding of what happened for you. And then I kind of walk them through. And of course, we do little side things. And honestly, they will not deliver the information neatly in the 4 levels. They jump back and forth. And so in my masterclass, I talk about, I have visuals for how to template it. Because, when we're talking about what happened, we're usually using words that were, convey how we either felt or how we thought about, or what our thoughts were and what our feelings were through the whole thing. So you're normally getting it at multiple levels. So there is this whole process of sorting it out as it's coming at you. So yes, you try to guide it, but do they deliver it in that beautiful, neat package? Not so much. So that is one of the skill sets I have to teach, and teaching people how to use this is how to go through and sort as it's all coming at you. The good news is it gets easier and easier with practice, but it is a skill set. It's a little bit of mental juggling there. And I do use Iron Man as kind of our little template there. You ever seen the Iron Man movies where he's got that little visual there? You get your own little Iron Man suit with this. Okay. So there's no psychoed to the second half of this question, but when I'm going through this 4-level assessment, I'm totally in their holodeck. So there's no psychoeducation going on whatsoever. Because I'm blindfolded and I can't see what's going on, I have to ask, so what's going on behaviorally? Okay, and so this one's the one pushing for change, this one's not, right? Or whatever the complementarity be. So then I will go through and ask, so at the beginning, how are you feeling, And then, and then as things got worse, what feelings, were you having? When things were at their worst, what were your feelings? And as things got back together, so you're feeling, okay. And then in terms of just feeling like, safe in this relationship, how did that ebb and flow? Okay, so that's, the emotional level. Then next level, cognition. So then we go back to the beginning. So look, I want to go back to the beginning real quick. So at the beginning, what kind of thoughts or feelings were you having? Your thoughts, not feelings. What kind of thoughts were you having about the situation, right? And then how did your thinking shift? And when things were at their worst and when things got back together, what were you thinking? And then how did you feel about yourself with identity level? So we just keep going up those 4 levels. So there is no psychoeducation because they're educating you. They're showing you the program for their holodeck is what they're doing. But it's also an intervention because most of us aren't conscious of how our holodecks are programmed. And we go like, oh, you're right. When that happened, this happened. When they said this, I felt that and I did that, and that probably didn't help, did it? And so they're also learning as you are going through this. So I hope that explains how those pieces come together. So, okay, this next one from Christina is, do you think a therapist's ability to understand his or her own 3-generation family system and emotional processes parallels his ability to provide effective psychotherapy? Well, yes, the Bowen therapists have actually done research on the more differentiated you are. You can only, that's only as much as you can help your clients to be differentiated. But again, those are part of the identity and level 4 dominant discourses, or what our family gives us, that and the beliefs, even those, those top 2 levels we get a lot from our family. Of course, they're also related to the attachment patterns we have. So they're reflected throughout the different levels. But yes, that is you doing your own work. That's why step 1 is self of the clinician. Going through, staying on your personal journey of development, where you're looking at your emotional reactivity, you're looking at your relationships, and that pulls into what you're talking about here with the family systems and emotional processes. You need to be constantly working and improving and tweaking that. Now, what I teach folks to do in my course, which is 5 months long, is we break it down to tiny little goals, tiny little 1 to 5 minute daily practices to just keep moving the needle forward. Because with human psychology, we know too much change, normally the homeostasis will push right back on that and you fail achieving your goal. So we work on using micro habits, micro goals to keep moving the needle forward. But the concept is, of course, throughout your whole life, you're moving forward in all 6 areas of wellness. And that definitely is going to make you a better clinician. I hope that makes sense. Okay, when you consider your approach more problem and assessment-based and less solution-focused or outcome-based, no, it's all of those. It's very solution-based. In fact, if you want to, you can just skip the problem assessment and go straight to the solution assessment. And for some clients, that's what you're going to do, because they're you can work that way. But solution-focused just kind of drops off that problem assessment. They do a little of problem assessment, but they always prefer to do a solution assessment. And I tend to, if there is a solution during the week, I almost always start there. It's very rare. I had some good things happen and some bad things happen, I always start solution based and then move to the problem, because I feel like I get more movement from the solution cycles than the problem cycles. And I would say this whole approach is extremely the whole thing is do what works. It's outcome based. It is not based on theory. You do what works. I don't care which theory you use to get you there. You do what works. You may be referring them out for functional medicine assessment to see, what type of food sensitivities or vitamin deficiencies are keeping them chronically anxious or depressed. You do what works. So it's 100% outcome based in terms of do what works. It's only about outcome. And that's really what matters. And I think many of us are too wed to our theories and our philosophies that we aren't looking at the evidence in front of us, and we'd rather blame the client than shift what we're doing to make it work for the client. So I would say it's extremely, extremely outcome based in terms of do what works. And it's do what works long term. It's not do what makes the client happy and like me. A client's liking me and being happy, I don't, even if their problems go away, I'm not impressed until I can see that they're able to significantly, change their behaviors. When the old triggers come, can they do something different? And so until I see that, they have not made change. So even if my client's happy and says they have fewer symptoms, I'm not thinking I'm done with my work, because they've not changed how they deal with their stressors. They haven't changed how they deal with triggers. So nothing has changed until you've changed that. I hope that makes sense. Got another one coming in here from Jen. Helping our clients with this unified model is awesome. On a larger level, how can we help as an advocate for global mental health? What organizations do you affiliate with for effective change at a global level? Well, right now my institute is the institute I associate with. And this video will be available to mental health providers all over the globe. And I actually do have often 4 to 5 different continents involved in my Therapy That Works master courses. And, I am also affiliated with the United States International University, in the sense that their students go through my Therapy That Works master course. And what I think is really exciting in parts of the world where they don't have this long established, heavy psychiatric based mental health system, I think they're going to be able to just start with far more efficient systems. And so you need to get people in places in a system of power to use more contemporary systems and not be chained to the past. And I think of my colleague Jaakko Sekula, who is a psychiatrist in the Lapland region of Finland. He oversaw, it's also socialized medicine there, so oversaw the psychiatric hospital working with psychosis cases, was influenced heavily by Tom Anderson, and was able to create this open dialogue approach. He's been developing it now, I think, for 30 years. That's incredible. Totally different approach to working with chronic, and there are no chronic cases of schizophrenia anymore. People have psychoses and they're successfully treated because Jaakko was in a position to change how that whole psychiatric unit worked and able to develop this whole new system. And so how do you want to change? You need to get good at what you do, get into a position where you have influence and power in an organization, and explore using some of these newer approaches that let go of a lot of the relics of the past that are just holding on to the tail of that, elephant, and are really able to move the needle forward, because what we're doing is archaic. All I can say is it just feels so archaic, and I can have all these conversations because I love theory. I've always loved theory. I still have totally emotional, endearing relationships to most theorists in our field. But at the same time, that's not what I need. That's not where I need to start my students. I do think doctoral students need to be studying all that old stuff and all the old detail. I do think what should be happening in doctoral programs so that they can continue developing theoretical models and such. But the average clinician, that is not where we should be starting them and focusing on. Hope that gave you some ideas for your future career, Jen. Okay, Anna Lynn. Okay, so Anna Lynn says, the 4-level assessment presumes the problem has been defined. What is your problem definition process? Hey, I am blindfolded. I walk into the client's holodeck and they're going to tell me what they think the problem is. They're coming to see me because there's a problem, right? So I want to hear what they say it is. And I guess to a certain extent, then I want to understand what they think is a problem behaviorally, what happens emotionally, what happens cognitively, what's happening at the societal, social location level. So they may have one definition, and I'm going to really understand it on all of these 4/8 levels. So I help them kind of thicken that. Now, when we work with a couple or family, they will often have multiple different definitions of what the problem is, and I make space. So when you're working with a couple and a family, it can be, especially in the beginning, it's like you're running into different holodecks. Okay, this is your reality. Wow, it doesn't even mesh with your reality, right? You can go over here and understand that one, and come back over here and understand that one. But eventually, thank God, they do tend to get more, okay, I can see how you both were part of the same argument. Sometimes it doesn't seem like it, right? You both went to the same party. But in the beginning, they can be very different. But I'm always working within the client's definition of the problem, but then trying to understand it so thoroughly. You can think of that 4-level assessment as I want to enter and understand how all these pieces fit together. And I don't stop until I can understand it at that level of depth. Okay. Okay. Mark's got another question here. So another question is, do clients look for the homeostasis or do clients look for a new perspective? Not quite sure I fully understand the question. Clients are just looking usually for a solution, give me the answer is usually what they're looking for. Is how most clients will construct it, how most clients phrase it. They just want, tell me how to solve this problem. So, and all of us, we kind of want change, but change is very uncomfortable. We don't want to be uncomfortable, so then we don't want to change. And so if you look at some of the classic family therapy models, they were looking at that push-pull, but that happens at all of our individual levels as well, which is why I use motivational psychology. So this is where I feel like something that psychotherapists need more of is looking at these micro habits, so I teach people in my master course how to practice with micro habit changes, micro goals, because that bypasses the homeostatic pullback to norm and allows change to happen. If you can keep change under the threshold where your psyche or the family doesn't need to push back against it, you can keep that change moving forward. So most people are going to achieve change most rapidly and consistently and maintain it if you have small little steps. So because homeostasis pulls most of us back into our old patterns very rapidly. Awesome. Okay, so Kenzie is asking, do you have any thoughts about acceptance and commitment therapy. It's a great approach. It's a mindfulness informed one. So I absolutely, it's got a special place in my heart. I would say they have some of the best metaphors in the entire field. And so, I would say the acceptance commitment therapy is another example of a CBT that has added many postmodern elements, a lot of them more Buddhist psychology, which is a deconstructionist more than social constructionist, but it is still postmodern. So that's a good example of a CBT approach that has evolved to have a lot of more postmodern elements. And it's usually more, though, described as Buddhist informed, because you're not. So those of you who aren't familiar with this approach, instead of trying to correct your irrational thoughts, they're learning you to accept that is the thought, accept the reality. So it's using this third way where you're not fighting your symptoms or correcting them as much. Instead, you are learning to accept them, and accept them not like you roll over and like, I'm just going to live with panic attack forever. No, oh, this is what happens. This is what scares me. This is the reality, And so it's not resisting. There's more of this kind of Buddhist embracing what is, and then from that position of non-resistance, looking at what type of steps you can do to change. So yes, and yes, existentialism is kind of underneath that humanistic umbrella, and the existentialism, it certainly hits at obviously that cognitive level. And in certain cases, it certainly hits that societal level. And I think those two pieces can work really well together. So, so that's, I think, the answer to those questions. You can map, okay, here's the honest to God truth. You can map whatever theories you want. I mean, there are 500 theories. I promise you, all of them map onto that template I just saw you. And the honest to God truth is, because you've got your holodeck, I've got my holodeck. And we even have it for our theoretical constructs. So if you map yours differently than I map mine based on who trained you versus who trained me, that's all good. I don't care. As long as you do therapy that works, which is you get good outcomes. So you don't get hung up on these little diagrams too much. They're there to help you understand, but they are not like some objective truth, because even when we're doing training, we're each in our own little holodecks. So I hope that helps. You can put them whatever way helps you remember them. I use this model and this framework, that 4-level assessment, for folks who are studying for licensure. And for a lot of them, it's like, oh, I can now see where things overlap, and you can map them any way you want to. That helps you pass your licensing exam. So, okay. Got one more question. Okay, from Jen. If you have a client coming to therapy week after week complaining about depression, and they continue to use weed and alcohol to treat it, what do you do? Okay, so she said she's referred them for group while working together, but they don't want to do that. I get stuck here and don't want to abandon clients, but feel a loss. Well, so that is where, so what you're doing then, that's definitely part of the behavioral cycle. This is why doing that behavioral cycle can be so helpful, is you're looking at where that, the alcohol or the weed is coming into the symptom cycle and how it makes things different, and how it affects the cycle. And then you're going to look at it at all the different levels, including how that affects their emotions, their sense of safety, their thoughts about themselves and others, their identity at those levels, what they think society is saying about them and people with their problems, how it links up with their social location in terms of age, gender, race, ethnicity, education level, all of that, right? Family of origin narratives. And so hopefully as you do that, right, you begin to, they get some new insights that might be motivating. I mean, certainly alcohol and drugs can have an addiction component to it. Then you hopefully get some solution cycles to look at, maybe where they didn't use any substances. Oh, look at those differences, okay? And so some folks are able to make changes like that. And then sometimes, they're not, and they need more formal intervention with addictions. And then we talk about it from within their worldview. And if they don't think it's a problem, I listen to why they don't think it's a problem. I try to understand how those pieces fit together. And because I do it from a sincere, curious perspective, sometimes I have those conversations, and as we map it all out sincerely, curiously, like we normally do, they're like, okay, yeah, maybe it is more of a problem than I like to make it out to be, but I'm just not at a place where I want to deal with it. I can't take a 30-day treatment program, and so I don't know what to do. So at least then we're having, then we can move to harm reduction. How do we have less of this problem? So you can move to a more harm reduction version. Sometimes you're like, yeah, I really do need treatment. I need to check myself in some place. So obviously it's all part of the conversation, but you're doing it from within their worldview. I'm not coming in and saying, you need to, and that obviously makes them run and not come back. So you have to engage in a way that makes sense for them, that fits within their worldview. And I do it from a non-judgmental perspective. And together we come up with the most reasonable solution for their current situation. And with compassion and empathy and honesty. And so that is where you can make change happen. Okay. So Mark is saying change is happening all the time, spoken like a true solution-focused trained therapist. So how can clients be assisted to move change in their preferred direction? Well, so that is where, it's a great question, Mark, because, often what I'm doing is I look at, whatever happened, whether it was the problem cycle or the solution cycle. Always try to start with the solution cycle first, because it's always more fun to talk about, both for me and for them. And we look at what worked and what didn't, and hopefully we can do more of that. And if there's more problems, then we can look at what happened there and where we want to change things. But we're just constantly moving. We're doing it with it. So what happens is when you are working with the client's worldview and you're doing this 4-level assessment of what worked, what didn't, noticing what happened with the rise of tension, the return to normal. When you're working and you notice these things, okay, because you're in the client's meaning-making system, their interpretive system, their consciousness, right? When they get insights, they cannot unsee them. So what is magical? Why is it the key is to get into that client's worldview? Because when you're in their holodeck, whatever insights they get when you're there, they cannot unsee when you leave. In contrast, if you offer them a reframe, if you offer them a cognitive behavioral, ABC thought record homework assignment, they can reject your reframe. They can reject your CBT, countering of their negative thought because it's external. But when you're in their meaning-making system, they cannot unsee what they just saw. It's like they get an insight and they can no longer notice that every time they get into an argument with their partner, there was a bottle of alcohol that came right before that, right? You can't unsee it when you're doing it in their meaning-making system. And that is why also when you introduce, look for interventions, bring the wealth of our knowledge into their worldview, it's very logical, natural. They follow, my clients do their quote unquote homework because they gave it to themselves, right? They come up with what to do 9 times out of 10. There are times I do come up with things where we work on it together, we collaboratively create something, but 9 times out of 10, they came up with it. They're like, obviously I need to do less of that. Okay, great. Let's see how that works this week. And then I keep it small. One of the other things we learn from motivational psychology, keep it small, keep it small. So if they want to do something this big, I normally make them dial it back and let's just try for this week. Keep it small, keep it small. But change is always happening and we're moving it in small directions. Sometimes they're huge leaps and sometimes they're small steps. Sometimes it goes backwards. And that also teaches the equanimity, which is key to long-term mental health. So I hope that helped there. Kenzie was saying, I think acceptance and commitment therapy fits, with the concept of equanimity. It does, because it's Buddhist informed. Equanimity is from Buddhist psychology, which I think offers all of us a much healthier, realistic, more sustainable definition for our long-term goal other than happiness, is we want equanimity. We want to be able to move with life's ups and downs gracefully. Okay. And then Christina is saying, would you recommend clinicians take a course in neuroscience? Well, those of you who are in grad programs, I hope you're getting some of that now. If not, reading a book. You can get some of the neuroscience through, I got a lot of my training through the mindfulness, has a lot of neuroscience kind of built into it. Neurofeedback does neuroscience, but definitely understanding, you don't have to learn EMDR, neurofeedback, or mindfulness, because mindfulness can definitely work as a brain-based intervention. Probably the easiest to use. You don't need to become trained in any of that. You just need to know when to refer for a brain-based intervention. And there's certain clients who typically chronic, severe trauma cases, ADHD, certain interventions, certain problems tend to do much better with a brain-based intervention. Okay, awesome. Mark said he liked that I recognized his solution-focused base. Well, yeah, and yeah, it's I love it. Okay, so Louise is asking, what if you have a client who comes in with all black and white thinking and all or nothing when it comes to change? All I can say is, Louise, I go into their holodeck and I understand how all that makes sense to them. And then, you can't help but comment to a certain extent, your own holodeck and assumptions and meaning-making system. And we'll just notice it. And it's amazing. Most of what I do is just noticing, identifying, putting into words what's never been said, but kind of how their system works. And sometimes when, you say, because this didn't happen, none of that stuff from before, you're counting as good at all. And you kind of go, it feels like everything is totally fatal. And then I could, everything was for naught. I say, does that seem like, when you step back and think about that, does that sound realistic to you? I mean, most of the time they say no, right? So the other question is that working for you? How is that making you feel? Do you think that's fair? If this happened to a friend or a child, would you, judge it so harshly? And so we discourse around it, and I stay within their holodeck rather than trying to hit them with a sledgehammer from mine. So, okay, so hopefully that resonated with you as well. Okay, well, I want to thank everyone for joining me today. And I hope that this introduction to the unifying framework has been uplifting and inspiring and giving you hope that, that this work can be far more easy than you may have been told it might be in your real world. I mean, in your graduate training. Sorry, I'm trying to read, make sure there's no comments I missed over here. So, but I do hope that this framework helps you thinking in new ways about how to do this work, inspires you to think, wow, this might be a lot easier, to do than I ever thought it could be. And I invite you to, check out, stay in touch with me if you're passionate about this, and I wish you all the best in your training. Thank you everyone for being here. I really, really appreciate it. Awesome. Thank you. Yes, I'm reading the comments here. That it is just really helpful to, it's like there's a relief that comes with this in terms of, oh my God, this can be so much easier. And I really do think the next decade ahead of us, we are just going to find such better ways to do this work. So awesome. Oh, I love it. Danny is citing one of my the mentors from within the collaborative tradition for me, although I never got to work with him personally. Harry Galushan said, love a theory, but don't marry it. So if you have some of the old editions of my book, I used to talk about dating versus marrying theories. But yes, absolutely. So thank you all for being here. And like I said, if you want to learn more, check out my Therapy That Works Institute. And a lot of us are kind of blazing some new trails and hopefully finding better ways to do this work.